Welcome back everyone to the last video presentation of the part 4 of the anesthesia overview. Today we are going to discuss some of the topics revolving around the airway. This video presentation is aimed at MRCS candidates whom I find this helpful in revising their exams. I will try to keep this session short and interesting. There is no conflict of interests and all videos were made for educational purposes only. The slide shows the learning objectives that we will be covering today, so please enjoy. Let us start off with the American Society of Anesthesiology ASA physical status classification system that has existed for over 60 years. The purpose of this classification is to assess and communicate a patient's pre-anesthesia medical comorbidities. One thing to note is that the classification system alone does not predict the perioperative risks, but it can be helpful in predicting perioperative risks when used with other factors, such as the type of surgery, patient's frailty status, as well as the level of deconditioning. The definitions and examples shown in the table below are guidelines for the clinician. Assigning a physical status classification level is a clinical decision based on multiple factors. While the physical status classification may initially be determined at various times during the preoperative assessment of the patient, the final assignment of physical status classification is made on the day of anesthesia care by the anesthesiologist after evaluating the patient. We now look at the Monro-Kelly hypothesis as a pressure-volume relationship that aims to keep a dynamic equilibrium among the essential non-compressible components inside the rigid compartment of the adult skull. It was first named after Alexander Monro, a Scottish physician, and George Kelly, a Scottish surgeon. The average intracranial volume in the adult is around 1,700 mL, composed of brain tissue which takes about roughly 1,400 mL of volume, cerebrospinal fluid roughly 150 mL of volume, and lastly blood, which is also around 150 mL of volume. The volume of these three components remains nearly constant in a state of dynamic equilibrium. Thus, a decrease in one component should be compensated by the increase in another and vice versa. However, it is important to know that most of the blood in the cranial cavity is contained in the low-pressure venous system. So venous compression serves as a means of displacing blood volume. This is a pressure-volume curve for intracranial pressure, which is mainly divided in 4 zones. In blue as the baseline intracranial volume with compensatory reserve and high compliance. Next, we have the yellow zones, shows a gradual depletion of compensatory reserve as intracranial volume increases. And then we have the red showing poor compensatory reserve and increased risk of ischemia and herniation. And lastly, the gray zone showing a critical high intracranial pressure causing collapse of cerebral microvasculature and disturbed cerebrovascular reactivity, which then leads us to look at cerebral perfusion pressure. Cerebral perfusion pressure, or known as CPP, is defined as being the net pressure gradient causing blood flow to the brain. Cerebral perfusion pressure is tightly regulated to maximize cerebral perfusion. A sharp rise in CPP may result in a rise in intracranial pressure, and a fall in cerebral perfusion pressure may result in cerebral ischemia, as shown in the formula. CPP has to be carefully monitored post-trauma, and an invasive monitoring of intracranial pressure and mean arterial pressure may be needed such as in the case of traumatic brain injury, like subarachnoid hemorrhage, diffuse axonal injury, or a comatose patient without significant findings on the CT head scan. The diagram illustrates the cerebrovascular autoregulation capacity between 50 to 150 millimeters of mercury, and any cerebral perfusion pressure which is below 50 millimeters mercury will result in ischemic brain injury due to hypoperfusion, and any CPP above 150 will signify hyperemia and edema due to hyperperfusion of the brain tissue. We are finally on the subject of definitive airway. Definitive airway provides oxygen-assisted ventilation via a cuffed tube present in the trachea, with the cuff inflated and the tube secured. Rapid sequence induction followed by orotracheal intubation is the most preferred method by the anesthetist as a primary method for definitive airway to ensure a safe and non-traumatic experience. Indications of definitive airway include apnea, inability to maintain airways by any other means, there is potential compromise of the airway, maxillofacial fractures or retropharyngeal hematoma, sustained seizure activity, and lastly, a Glasgow Coma Scale of less than 8. Types of definitive airway include orotracheal, nasotracheal, though contraindicated in suspected base of skull fracture or maxillofacial injuries. Other means of definitive airways include cricothyroidotomy and tracheostomy, which could be achieved surgically. The diagram illustrates orotracheal, nasotracheal, cricothyroidotomy, and tracheostomy intubation, respectively. When considering lung volumes, it is useful to divide the total space within the lungs into volumes and capacities. These allow an assessment of the mechanical condition of the lungs, its musculature, airway resistance, and the effectiveness of gaseous exchange at the alveolar membrane. Furthermore, there are generally cheap, non-invasive, and simple tests available. In this presentation, we will look at the volumes and capacities within the lungs, how they can be measured, and how they are affected by pathology. Capacities are composites of two or more lung volumes. They are fixed as they do not change with the pattern of breathing. You can pause the video presentation if you wish to look at the lung volume diagram in more detail. Let's now focus on the concept of dead spaces in our respiratory system. It is the portion of each tidal volume that does not take part in gaseous exchange. I guess the key word lies within each tidal volume. Physiological dead space is a summation of anatomical and alveolar dead space, and both anatomical and alveolar dead space is roughly equal at about 150 mL in a healthy human. This is calculated to be roughly 30% of the normal tidal volume of an adult, which is 500 mL. Alveolar dead space is increased in patients with respiratory diseases that could potentially reduce recruitment of the alveoli to take part in the ventilation and perfusion process of the gas, such as in patients with COPD and chronic bronchitis. The next concept would be inspiratory to expiratory ratio, which expiratory is twice as long as inspiratory ratio in normal spontaneous breathing. This would give the IE ratio of 1:2. Then we have FiO2, which is a description of the fraction of inspired oxygens at the alveolar level. For example, If a patient is receiving 10 liters of oxygen per minute with an FiO2 of 0.21, it means that 21% of the inspired oxygen will take part in gaseous exchange at the alveolar level. FiO2 should normally be chosen to achieve a normal SpO2. If an FiO2 is more than 0.5, the aim of oxygen saturation should be at 92% once other ventilator settings have been optimized. This is termed permissive hypoxia. Relative hypoxemia is also tolerated in some patients who are chronically hypoxic. Understanding oxygen delivery and interpreting FiO2 values are vital for the proper treatment of patients with hypoxemia, especially in the critically ill, has shown to increase all-cause mortality. When oxygen consumption and supply are mismatched, cell damage and death could occur. The key is recognizing the cause and thus the appropriate route of treatment. The next and final concept that we're going to discuss today is positive end expiratory pressure, also known as PEEP. PEEP is the positive pressure that will remain in the airways at the end of the respiratory cycle. This pressure is greater than atmospheric pressure in a mechanically ventilated patient. The initial PEEP for patients admitted to ICU is usually between 5 to 10 centimeters of water. Now, let us take a look at the non-invasive ventilation, which refers to the administration of ventilatory support without using an invasive artificial airway, as we discussed earlier. Examples of non-invasive ventilations are high-flow nasal cannula, negative pressure ventilation system, though rarely used nowadays, continuous positive airway pressure, CPAP, and lastly, bilevel positive airway pressure, BiPAP. The figure shows the setup principle of a high-flow nasal cannula oxygen therapy. An air/oxygen blender allowing from 0.21 to 1.0 FiO2 generates up to 60 liters per minute of oxygen flow. The gas is heated and humidified through an active heated humidifier and delivered via a single limb heated inspiratory circuit. The patient breathes adequately heated and humidified medical gas through nasal cannulas with a large diameter. While there has been no big randomized clinical trials on this, it has been gaining attention as an innovative respiratory support for critically ill patients. Most of the available data has been published in the neonatal field. Evidence with critically ill adults are poor. However, physicians apply it to a variety of patients with diverse underlying diseases, such as hypoxemic respiratory failure, acute exacerbation of COPD, post-extubation, pre-intubation oxygenation, sleep apnea, acute heart failure, and patients with the do not intubate order, and so on. Many published reports suggest that high-flow nasal cannula decreases breathing frequency and work of breathing and reduces needs of escalation of respiratory support in patients with diverse underlying diseases. Next image shows Mr. Paul Alexander, who contracted polio when he was 6 in the negative pressure ventilators, also known as the iron lung back in the days. Negative pressure ventilators is a form of NIV to provide ventilatory support using a device that encases the thoracic cage, starting from the neck, and devices range from a whole body tank to a caress shell. The general principle is the same with a vacuum device, which lowers the pressure surrounding the thorax, creating a sub-atmospheric pressure and thereby passively expanding the chest wall with diaphragmatic descent, all leading to lung inflation. Exhalation occurs with passive recoil of the chest wall. This was the predominant technology during the polio epidemics, but these devices were bulky and cumbersome to use. Upper airway obstructions and mucus plug was also a problem with these devices. These ventilators have been largely supplanted by the more widespread positive pressure non-invasive ventilators, as we're going to discuss later. However, some patients continue to be treated with this modality. Lastly, we have CPAP and BiPAP left on the list as a method of non-invasive ventilation. The key points of CPAPs are: the machine provides continuous pressure throughout the respiratory cycle. Patients initiates all breaths. It is suitable for type 1 respiratory failure, hypoxemia, without hypercapnia. CPAP machine facilitates alveolar recruitment by reducing ventilation to perfusion mismatch. It contains a PEEP valve. It is indicated in acute cardiogenic pulmonary edema and heart failure. And also, sometimes the use could be seen in the case of severe pneumonia, obstructive sleep apnea, and atelectasis. The key points of BiPAP are: first of all, it is a bilevel positive pressure that includes inspiratory and expiratory positive airway pressure. The users operating the BiPAP machine are allowed to preset inspiratory and expiratory pressure, as well as setting a backup respiratory rate. The patient initiates breaths and is suitable for type 2 respiratory failure, which is hypoxemia and hypercapnia. BiPAP works by increasing the tidal volume and reduces carbon dioxide in the lungs, and is indicated in COPD with CO2 retention, post-extubation, or prevent intubation or re-intubation. The pressure time graph illustrates the presence of PEEP in both CPAP and BiPAP. As discussed, BiPAP has inspiratory and expiratory positive airway pressure, and with the expiratory positive airway pressure, also known as PEEP in the case of BiPAP. Though ventilators are great at providing oxygenation and respiratory support, but it can too induce acute lung injury, which carries significant morbidity and mortality. The main elements of these are barotrauma, volutrauma, atelectrauma, and oxygen toxicity, respectively. Barotrauma is the damage to the lungs as a result of high airway pressures, especially plateau airway pressures of over 30 centimeters of water. Next on, we have volutrauma, which is the damage to the lungs as a result of high tidal volumes, usually more than 6 ml per kilogram in patients with ARDS. Next, atelectrauma is the damage to the lungs as a result of cyclical collapse or atelectasis and the opening of the alveoli. Atelectrauma can be prevented by the use of an appropriate level of PEEP. Last but not least, oxygen toxicity is the damage to the lungs as a result of prolonged exposure to high FiO2. The mechanism is uncertain, but it is thought that high FiO2 results in generation of high levels of free radicals, which are toxic to the lung tissue. Thank you very much for listening, and this video presentation marks the end of the series of anesthesia overview. And please stay tuned for more MRCS related exam topics in the near future. Bye bye!